Good evening to everyone and welcome to today's wonderful evening. Hyderabad is all pouring with water, and I became so busy in clinical practice almost from morning 9 o'clock to night 11 o'clock, patients, critical care, emergencies, and admissions. Still, while traveling from the hospital to the clinic, I thought, why not in the car? I take a class for you all. So sometimes there can be an interruption because of this Hyderabad traffic. So, uh, but still, I hope I'm audible and nice to see Anita Rani. Can you please punch? Is my voice loud and clear for all of you, doctor? Can you please punch? So sometimes there may be interruption because of the internet, but overall it will be a good ride while I'm traveling in Banjara Hills in the full traffic. Today we are taking a class in NEET PG surgery revision all the way from in the middle of a rainy traffic, right? So let's make the great beginning, doctor. Yes. Now the various types of cysts. Cysts can be congenital, like the dermoid cyst, thyroglossal cyst, urachal cyst. There can be retention cysts, like the sebaceous cyst, Bartholin cyst, ranula. Similarly, there can be false cyst. What is the false cyst? It does not have any epithelial lining, like the pseudocyst of the liver or pseudocyst of pancreas is what you need to remember. So, 2, 3 points about ranula. So, what is ranula? Ranula is a retention cyst because of the obstruction of the salivary glands. And we call plunging ranula whenever there is any extravasation into that cyst because of the obstruction and rupture of the sublingual salivary glands is what you need to remember. So this is a typical image-based question about ranula, which you need to identify. And this is an example called plunging ranula is what I want to underscore to all of you. Now, what are the, thank you Anita for the feedback that the voice is good, clear, and loud. Yes. So, uh, yes. Let us look into 1 minute. Just let me. Yes. So, what are the various fluids of choice for correction of dehydration in diarrhea? Always remember ringer lactate, normal saline, they are the fluids of choice. If you want to improve the microcirculation, then we need to use colloid. Dextran 40 is an example of a colloid. Then what are the plasma expanders, doctor? Dextran, albumin, hetastarch, etc. Similarly, there is a very important scenario where normal saline is given and dextrose containing fluids are specifically avoided, especially in neurosurgical cases or in the patients of stroke. Normal saline is given and dextrose containing fluids are avoided is what you need to remember. A lot of times questions are asked about the various fluids, their composition, and what is their osmolarity, etc., etc. So now let us look into this specific scenario. Normal saline, what is the osmolarity? 308. And how much sodium is there in 1 liter of normal saline? 154. And where is normal saline? A fluid of choice, doctor. Shock, dehydration, hemorrhage. But it can lead to, because you are pumping chloride, That's the reason hyperchloremic metabolic acidosis, which is of normal anion gap type, can occur when you have bumped a lot of normal saline into the patient. Just 2-3 points you should know. Now, lactated ringer, typically osmolarity is 275, sodium in it is only 130, and it is a fluid of choice for replacement in shock, dehydration, hemorrhage. Of all the fluids, which is the one which is most physiological? It is the ringer lactate. But one thing you remember, R for ringer lactate should be given carefully in R, that is renal failure, is what you need to basically remember. I'm so happy to see 10 online classmates. So today I made about 4 critical cases admitted, and there was a case of Russell viper bite. Patient had pulmonary edema. We have given 80 milligrams Lasix, completely relieved the pulmonary edema. Patient's hypoxia has improved. So that is the reason, doctor, whatever that we study, remember, whatever that we study, that all comes in the practice. And the moment when you are practicing as consultants, you need to apply all what you are learning now. That's the reason, don't think what you are learning, all this will go wasted for the entrance exam, whatever you are learning, right? So I thought I'm not able to get time, because almost morning 8 o'clock onwards, all the critical care patients up to night at 10:30, 11, I'm occupied. So I thought, whenever I'm traveling in rain, in crowded street, 1 hour anyway I need to sit in the car. So why don't I spend 1 hour of time in discussion with all of you, right? Hope the voice is loud and clear for all of you. So, doctor, if you take the IV fluids, most physiologically is ringer lactate, but you need to use cautiously in renal patients. Then coming to the 5% dextrose, osmolarity is 285, and it contains 50 gram per 1 liter. Dextrose will be there. And mainly, where do we use dextrose 5%? Let us say there is a patient who is dehydrated, he needs free water. Then if you want to give free water, then dextrose 5% is good in dehydrated patient who has hypernatremia. Similarly, preterm neonates who are day 1 and 2 fluid, for the very low birth weight preterms, then in all of them 5% dextrose is the preferable fluid. So 10% dextrose is having 285 as osmolarity, 100 grams per liter of dextrose. And neonates who are day 1, day 2, who require fluid, or hepatitis patients, because if hepatitis is their liver is damaged, you are going into hypoglycemic episodes, there the 10% dextrose is the fluid of choice, is what you need to know. Similarly, dextrose 5%, with ringer lactate. Similarly, dextrose with normal saline. Whenever initial post-operative maintenance you need fluid, then dextrose 5% with ringer lactate or dextrose with normal saline is the very good fluid which is used in the initial post-operative maintenance, is what you need to basically remember. Wonderful to see 13 online classmates. I'm feeling very sad. Oh my God, I became very busy in clinical practice, running around. I'm missing my students. That's a kind of guilt I'm passing through. But thanks to be my joining the session, whether it is earthquake or cyclonic storm, my promise is every day to spend at least 1 hour with you wonderful guys. So we have 1200 pages of notes I have given to you. If you did not get it, please today only acquire it. There are totally 600 hours of video in the Score Learning app. So please download it. There are 50 full-scale grant tests. Every Sunday we discuss live online, take the tests, and every day participate in this 1 hour of live session. Whatever be the scenario, whether I am in ICCU, MICU, or in emergency room, or traveling in the traffic, my commitment is I'm going to spend 1 hour time with you. Right, doctor? So let's continue. Please remember that isolate P in 5% dextrose. Totally 75 plus 265 is the osmolarity. It provides 170 calories. Too much of that can lead to metabolic alkalosis. Isolate M, it has osmolarity of 390. Typically, it is the perioperative fluid of replacement is what you need to remember. Now, quickly tell me, doctor, 5 P's of granulation tissue. Pink, punctate hemorrhage, pulseful, painless, pinhead granulation. P, about granulation tissue. You know, there are two types of healing. Healing by second degree, healing by primary. So more granulation and fibrosis is seen whenever the healing happens by secondary intention. And whenever you give an incisional wound, it heals by primary healing. A full thickness wound that is not sutured will heal by secondary intention. That's what you need to remember. So this is the 5 P's about the granulation tissue, which you should not forget. Now, what are the types of surgical wounds? This is another bomb-like question, which is the favorite question of the examiner. You need to be very sure about. It is a clean wound if it is an elective procedure. Similarly, if you don't enter into respiratory, alimentary, urinary, genital tract, when you do surgery, it is clean. Whenever you don't open a viscus, if there is no breach, so fibroadenoma excision, hernia repair, classical question. What are these? What is your answer? Clean wound. Then what is clean contaminated? There is a minor breach. Respiratory, alimentary, urinary, genital tract is already entered, but minimal spillage. Laparoscopic cholecystectomy is example of clean contaminated. If there is a major breach, you call contaminated, like bowel anastomosis. Dirty, if there is any traumatic wound more than 4 hours duration, like incision and drainage of an abscess and a perforation peritonitis, they are all examples of dirty wounds is what you need to remember. So we need to know about the wound dehiscence. Abdominal wound dehiscence. There are two types: burst abdomen, facial dehiscence. It is a severe post-operative complication which occur on 5th to 7th day, and it has got a mortality rate of as much as 45%, as what you can see. And this is an example of a classical wound dehiscence is what you need to remember. So now let us talk about Staphylococcal surgical infections. Boil, otherwise called furuncle folliculitis. It is an acute staphylococcal infection of the hair follicle with perifolliculitis is what you need to remember. Now, hidradenitis suppurativa. It is also painful. Follicular epithelium in the apocrine sweat glands is affected. Then carbuncle. It is the infective gangrene of the skin, mainly due to localized staphylococcal infection seen in diabetics and immunocompromised patients. So this is an example of boil, which is furuncle. This is an example of the carbuncle, and now if we talk streptococcal, let us say streptococcal surgical infections, you should know four important terms: necrotizing fasciitis, impetigo, cellulitis, erysipelas. These four are examples, classical examples of the streptococcal infection is what you need to remember. Can you please punch to tell whether the voice is loud and clear, doctor? Because bumpy, rainy roads of Hyderabad, where I'm traveling from hospital, so I don't know whether the voice is loud and clear. Can you please punch? Is the voice loud and clear for all of you? Right? Yeah. So I hope, yes, sir, loud and clear. Thank you, Megaswena. Yes. Now, doctor, non-bullous. What is also a form of impetigo? Painful fluid in the pus field source and it is a due to Streptococcus pyogenes, and sometimes erysipelas can spread to the pinna and ear sign. And what is the other name given Streptococcus? Flesh-eating bug is the name given to the Streptococcus. So this is an example where you can see the Streptococcal erysipelas and ecthyma classically. Now coming to Staphylococcus. Staphylococcus is one leading to carbuncle whenever it is localized, or it lead to staphylococcal toxic shock syndrome. Typically, erysipeloid disease caused by staphylococcus is seen in, is also called fish handler's disease. Then what is Pott's puffy tumor, doctor? All the diffuse external swelling in the scalp due to the subperiosteal osteomyelitis of the frontal bone is called Pott's puffy tumor. So this the Pott's puffy tumor is spotted in the tomorrow's exam, and also you can see the periosteitis caused by it. Then coming to infective gangrene, very good. Nice to know, Rituraj. Sir, I have just given my final MD exam. I was one of your student. Thank you so much, doctor. Proud to know that. So, synergistic spreading gangrene. Where do we see? Diabetics, immunocompromised. Melanie synergistic hospital gangrene. It is due to abdominal wall infection. Fournier gangrene is scrotal gangrene. Gas gangrene is caused by Clostridium perfringens is what you need to know. So this is an example of what you see. Fournier's gangrene is what you need to remember. Similarly, this is an example of yeah. So this is Melanie synergistic hospital gangrene. Now, what are the most common cause of laparotomy in a surgical patient? Laparotomy in a, suppose a patient who has undergone surgery. Laparotomy in surgical patient, it is the cytomegalovirus gastroenteritis. Whenever there is any formed abscess, always abscess anywhere need to be drained. So incision and drainage. Similarly, for a cold abscess, it is tubercular and anti-tubercular therapy is the treatment. Now, what are those swellings which are brilliantly transillumina, ranula, cystic hygroma, primary hydrocele, epididymal cyst, and meningocele. These are all considered to be the swellings which are brilliantly transilluminant is what you need to remember. Then what are the swellings which are cross-fluctuant? Compound ganglion of the palm is a classical example of a swelling which is cross-fluctuant. Which are the swellings that move with deglutition? Any subhyoid bursitis, thyroid swellings move up, thyroglossal cyst, laryngocele, extrinsic carcinoma of larynx, enlarged paratracheal lymph nodes. They're all the swellings that move with deglutition. Then what are midline swellings? Thyroglossal cyst, it moves up with the protrusion of the tongue. Similarly, Ludwig's angina is midline, acute, painful, and tender. Then subhyoid bursitis, it is also inflammatory swelling. It moves up with swelling but not with protrusion of the tongue. Subhyoid bursitis. Similarly, retrosternal goiter presents with dyspnea and dysphagia. So this is an example, this is here and it moved up. Thyroglossal cyst with the tongue in place, with the tongue protruded, it will move upward. Classical example. This is another example. The swelling moves up when the tongue is protruded, thyroglossal cyst. Even the thyroglossal fistulous opening moves up when the tongue is protruded. Now, what is sublingual dermoid? Typically, it is a congenital painless swelling under the tongue. Is the sublingual dermoid. Then what are the lateral neck swellings? Commonly lymphadenopathy. Similarly, right parotid swelling, you can see here, adenolymphoma. So they all present like a lateral neck swellings is what you need to remember. Now, what are the 5 P's of sudden arterial occlusion? Whenever any embolic event is there, pain, pallor, pulselessness, poikilothermia, paresthesia, paresis. And 6th P is paralysis. So the 5 P's of sudden arterial occlusion is a favorite question in the exam. Now quickly tell me, doctor, what you know about Buerger's disease. 10 points about Buerger's disease. Let us start. Small and medium sized arteries, an occlusive disease in the distal upper and the lower extremity. Lower extremities are plantar, tibial, radial, ulnar, etc. The disease starts in plantar, palmar, radial arteries and progresses proximally. It affects plantar more than the tibial arteries. So plantar is more common. Now, what will Buerger affect? What the Buerger doesn't affect? It affects artery, vein and nerve. Lymphatics are not affected. Usually male smoker, less than 30 years of age is a classical example. So this is what you call as the Buerger's disease is what you need to remember. So in a pregnant woman in this given case, there is a development of Buerger. This is a little atypical presentation of Buerger. So now what is the clinical triad of the Buerger's disease? There is a pain on exercise, claudication of the upper affected extremity, Raynaud's phenomena, recurrent superficial thrombophlebitis, but very important thing, if it is atherosclerosis, then it is not Buerger. Buerger is non-atherosclerotic occlusion. Remember, always, somebody has diabetes, hypertension, atherosclerosis, then you don't call it as Buerger. So, less than 30 years of age, smoker, claudication of affected extremity, along with Raynaud's phenomena, recurrent superficial thrombophlebitis, you call it as Buerger is what you need to remember. So, there is a criteria for the Buerger. Buerger is also called Thromboangiitis Obliterans. Shia Noya's criteria. Number 1, smoker, male, disease starts before 45, distal extremity involved first without any atherosclerotic embolic features, no diabetes, no hyperlipidemia, with or without thrombophlebitis. That defines Burja. If you do angiography, what do you see? Corrugation of the femoral arteries is classical. There's a smooth tapering of the segmental lesions in the distal vessels, which is called the corkscrew pattern. And there are collateral vessels which are seen at the vascular occlusion. There's a gangrene of the toes and fingers. There's a pan-angiitis, involves arteries, veins, and nerves, all the three. Internal elastic lamina is preserved, and a cellular inflammatory thrombus develops inside the vascular lumen. So these are the points you need to remember about the Burger very clearly. So all these points, doctor, many times earlier also we have discussed. So you need to be very sure. And these are all available in the Score Learning app. So today only subscribe, download, and prepare for the exam. Very little time is left. So this is the corrugation of the femoral arteries, which is very classical of Thromboangiitis Obliterans. So how do you treat? Stop the smoking, lumbar sympathectomy. It will relieve rest pain, gangrenous frost, ulcer, everything. Amputation of gangrenous part. And not related to old age, not related to diabetes, not related to atherosclerosis, then you call it as Burja, is what you need to remember. So with this today, we will conclude our long session, doctor, and enjoy a great evening, whether it is earthquake, rain, traffic jam. I'm very much there to spend time with you every day. Some days half an hour, some days 1 hour, whenever energy is there, 2 more hours. But all these things which we discussed, we already discussed this and made available in the Score Learning app, and revise. Okay, so today only subscribe, get the 1200 pages notes where 50,000 high yield facts are there, 100% strike rate. All 200 out of 200 questions in tomorrow's NEET PG every year come from these 1200 pages notes, which I courier you when you join with us. So prepare well. Be part of our WhatsApp study group, and I will help you 24x7 to support you, motivate you to prepare. Signing out, Dr. Murli Bharadwaj.